Yeah, that's right. All right. Welcome, everyone, to today's Berman Institute of Bioethics seminar series. I am delighted to welcome and introduce Dr. Michelle Munyikwa. She received her MD from the University of Pennsylvania in 2021 and her PhD in anthropology in 2019. She works at the intersection of medical and political anthropology, examining the interactions of trauma, history, and the law in practices of care in the United States. Her book project, The Spatial Promise of Refuge, explores these questions in the context of Philadelphia. Dr. Munyikwa has additional interests in medical education across the spectrum. She has conducted several curricular development projects dedicated to integrating social sciences and humanities concepts in medical education. Her work in this regard has been published in Academic Medicine and the New England Journal of Medicine. Currently, she's a resident physician in combined internal medicine and pediatrics at the University of Pennsylvania, and she intends to pursue further training in infectious diseases. So, welcome.
Hi, everyone. Thank you so much for having me. It is great to be here. It's been a long time since I've been to Baltimore, and I think the city is lovely as ever, although I will encourage you all to come visit in Philadelphia whenever you like. Before I get started, just so I have a sense of who I'm speaking to, better, like that, better, okay. Before I get started, so I have a sense of who I'm speaking to, I'd love to get a sense of who in the room would identify as a clinician of any kind. Okay, great. How about public health folks? Okay, ish. And then ethicists. Everybody, excellent, great. Wonderful. So as Deborah said, I am an anthropologist primarily, and then I work right now as a resident physician. I'm in my third year doing combined training in internal medicine and pediatrics, which means I spend the vast majority of my time taking care of patients and thinking about how we can take better care of patients. I am going to be talking to you today about things that are actually not really related to my doctoral research, but are kind of related insofar as the things that I was thinking about in my dissertation kind of carried forward with me as preoccupations as I started thinking about clinical medicine. And that's mostly because in the course of my dissertation, thinking about humanitarian practices of care, I was thinking a lot about what care feels like, both for the people receiving it and for the people doing it. Thinking a lot about affect and race and empathy, and thinking about how we feel our way through the proper thing for people. And so as I started doing clinical medicine full time, those were the kinds of things I was thinking about, especially in my first year of training, when I have the most face-to-face time with patients and thinking about how to do that right, what doesn't feel right about it. And so I wanted to contextualize that as sort of the framework with which I'm coming to speak with you today, which is basically that this weekend, for example, I did a 24-hour shift in the pediatric hospital, and I'm mostly thinking about like what interactions work and don't work, and how we can use resources from within clinical practice and also outside of clinical practice to take care of both ourselves and our patients. So I gave a version of this talk to my residency program a few weeks ago, and I started with this slide, which got a lot of knowing chuckles from the people that I work with, because I think it's probably not a surprise that it doesn't always feel excellent to do residency, and that there is indeed a lot of moral distress. And when I asked people to tell me about the last time a patient situation caused them significant distress, in a room of about 20 physicians, everyone could think of something within the last week, often within the last day or two. And I think that highlights the fact that there are lots of things that are happening in this context that are really not fantastic. People wanted to talk to me about how, for example, payer issues and access to care impacted their ability to take care of patients. They wanted to talk to me about how differences in cultural values between them and their patients impacted how we would make decisions. They wanted to talk about conflict, a lot about conflict. Conflict between themselves and other providers, between interdisciplinary members of the care team, between themselves and families, between families and us. Which is just to say that it felt like a huge problem that people were hungry for information about. And full disclosure, the reason I decided to give this talk this way about this stuff is because it's also something that I'm struggling with. And so I want to sort of situate the talk today in the setting of a case that I think about all the time, that I tell people gave me my very first gray hair in residency, and which happened almost 2 years ago. So imagine that you are me. You are caring for a 3-year-old girl on the inpatient floor. We'll call her Lily. And she has a rare genetic disorder that impacts growth and development. So it's pretty common at CHOP, which is a very ordinary care pediatric center. So we have a lot of patients with complex conditions that maybe sometimes no other people have, or maybe a handful of people have. And Lily is one of these children. She initially came in with pneumonia, got over that. And then while she was there, we discovered that she actually really wasn't growing and in fact was losing weight. But the challenge, of course, is that the average life expectancy of her condition was such that she wasn't expected to live even to the age that she was at the time. And it wasn't clear, because there's really no data, whether or not she could grow at all. But it is normal and commonplace in pediatrics for us to consider adequate growth something that we really want to focus on in children. And we very often have children who are hospitalized for the simple purpose of making sure that whatever they're eating will enable them to grow. So she'd been in the hospital at this point for several weeks past the resolution of her pneumonia. And when I came onto the team, there was already a very fraught scenario where the relationship between Lily and her mother, Lily, who honestly was not particularly verbal or interactive, but her mother, Rachel, was very active in her care. And there was a lot of conflict between Rachel and our nursing team. Very often, by very often, I mean somewhere between 5 and 10 times per day, I would receive notification from other members of the care team that there was conflict happening with Rachel. There was a sense that she didn't understand what was going on, that she was difficult, and that the way that she communicated with the rest of the staff was thought to be really disrespectful. And so in the backdrop, certainly, of course, the thing that we were concerned about was trying to figure out, one, if Lily could grow, and two, how are we going to facilitate that? But as a lived experience of taking care of Lily, my primary thing that I was really dealing with was, how do I manage the conflict between the people who are supposed to be caring for Lily and the person who is arguably the most invested in her trajectory? So with that, I'll talk a little bit about other things. So my goal for today is to think about what it means to do medicine in an unequal world. And I'll talk about structural competency, which is the framework I always use to talk about these issues before I was a resident. I worked very closely on Penn's curriculum for first-year medical students around the sort of practice of medicine, using structural competency as a framework, partially because of what it was like when I actually first started medical school. I'll talk a little bit about burnout and moral injury and distress, thinking about the ethical imagination, as well as some anthropological insight, and then end with a thought about institutional complicity and clinician distress. So, medicine in an unequal world. I cope with I cope with my job through humor, if you could not tell, and I want to start by talking about inequality. So one simple model of thinking about how we can consider systemic bias and other forms of bias is through this sort of framework of individual oppression and bias, thinking about people's beliefs and actions that serve to perpetuate oppression, thinking about the interpersonal interactions between people, and then moving forward to institutional and structural inequality. When I started medical school, which was in 2011, and I got to Penn, my doctoring course looked a little bit like Hispanic people really believe in church, and so you should think about appealing to religion for them. X types of people really respect authority and really want us to have a firm hand with them. A lot of cultural stereotypes that you would never believe were actually being said in the 21st century, but were 100% the total context of the kinds of education I got about what it means to care for patients across difference. And then every once in a while, there would be a trickling of the interpersonal, right? Okay, given that, X type of person likes authority, how are you going to embody that to help further their care? Which is, problematic for a variety of reasons. And so we were very excited when we could at all start injecting the institutional and structural insights that we were hoping would help us transform the way we take care of patients, especially in a city like Philadelphia. And so we started working with the concept of structural competency, which Helena Hansen and Jonathan Metzl have popularized, basically thinking about the idea that among the many other competencies that people who are clinicians and healthcare providers could possibly have, both like, clinical competencies, like being able to do physical examinations or make differential diagnoses, those kinds of things, that we would also be able to have a more structural lens that would help us understand how the things that we were seeing in our patients were the outcomes of long processes that often were not readily apparent to us, that would require some investigation, much the way that you would think about investigating symptoms and signs that were not clearly apparent, like what they were being caused by. And so what that looked like was essentially enhancing the social determinants of health curriculum, which if you would believe it, actually lived alongside that cultural stereotype curriculum, right? So there's the cultural stereotypes, and then there's also like poverty makes you sicker, but not a lot of interaction between why some people are poor and what that might mean. Deborah looks very disturbed. So we're like, okay, like part of our curriculum is going to be about why is there poverty and inequality? Where did that come from? Why is inequality unequally distributed? Why are there some patients who seem to have all the access to care, all the access to resources, to housing, to better insurance plans, et cetera, and others who do not? And that involves talking about policies and economic systems and social hierarchies, i.e. structures. As an aside, I think that one of the challenges of this, besides, the many things, is that I think it's increasingly difficult to talk about this while also maintaining the supposed political neutrality of a medical education, right? And so it's very hard, I think, in practice to talk about the economic systems that lead to inequality without taking particular positions about better and worse economic systems. But I can tell you that that is what at least our curriculum attempts to do, to, I think, the dissatisfaction probably of both people with more radical political beliefs and people with more conservative political beliefs. But I think there's this attempt that we do to sort of toe the line of like evidence-based observations about what kinds of policies lead to unequal outcomes. So this is sort of the framework that I both taught and learned myself as the framework that would help me understand what was going on in the clinical context and what I carried with me into residency. And part of what we talk about in terms of what that actually looks like as a competency, right, is just first being able to understand what structures are shaping your clinical interactions. Being able to talk about that in a separate language, much like you learn the language of the clinical context, different ways of describing the physical exam or different labs, you might be able to learn different language for talking about the social structures around you. Rearticulating that cultural formation that I was talking about previously in some structural terms, or at least being able to merge the two, thinking about what structural interventions look like, which admittedly might be outside of the purview of like the individual clinician, but are still sort of our collective obligation as people who are invested in population level health, and then thinking about what structural humility might look like. So that's the framework with which I was thinking about really. And for me, I was trying to think about, what are the structural factors that were potentially contributing to Lily's outcomes, right? So what I can tell you, for example, is that Rachel was an Afro-Latina, actually from Baltimore, had been transferred to the Children's Hospital because of the complexity of her care. And I think had an interactional style that I think would be perfectly consistent with the background that she was coming from, right? From her perspective, deeply, every time I spoke with her, she was like, I wasn't raising my voice. I was just talking, right? I'm not upset. This is what my face looks like. I come from a very direct culture. I like to be direct. I like there to be nothing that I'm not saying that people don't understand. And from the perspective of our nursing floor, which I can say at that time was primarily young white women in their 20s, there was a sense that there was something very like affronting about the way she was coming at them because of what I would describe as an interactional style that prefers beating around the bush, right? And so was all well and good, but it didn't necessarily help me understand the later ethical conundrums that would come up in the case. I could figure out like, okay, something is happening here around where people are from and how they talk with one another and how they have to advocate, right? Rachel felt very strongly that given her background and the fact that she was in an affluent white institution, that she needed to advocate very strongly for her child to get the things that she needed. At the same time, like very clearly, everything that she was doing was somehow at cross purposes with that in a way that really caused her a lot of distress and honestly caused everyone a ton of distress. And so she felt really strongly that she was being treated unfairly. The other challenge, of course, was that in addition to the fact that there was a major difference between how Rachel thought she was communicating and how she's being perceived, there was a huge difference between what Rachel wanted for her child and what we wanted for her child. So from Rachel's perspective, she was like, there's no place that I want less for my child with an uncertain prognosis and life expectancy to be than the hospital. I want her to be at home. I want her to be at home with her other siblings and my family, and I want us to go home to Baltimore as soon as possible. And it is a major strain for me to be here, like sitting in this hospital watching my child who may or may not be able to grow. On the other hand, there's a rigid, frankly, medical legal framework from the perspective of the team that was like, we can't send home a child who's floridly malnourished and may or may not have a cardiac arrest in the coming days if we haven't proven to ourselves that we can't help her grow. Of course, there's always complications, more than that even, which is to say that in this case, Rachel was also insistent that she should be the one to feed her child, right? So instead of using the sort of like standard formulas that the hospital has for children, she wanted very strongly to make her own food. It was part of her caregiving for her child. She wanted to decide what ingredients were going to go in there. She felt really strongly that one of the reasons why her child had lived so long was because she had been given like organic foods and fresh fruits and vegetables and few chemicals, and that was part of the reason why she'd lived longer than any other child with this disease. And she was like, one, you have to send us home, and two, this is what I'm going to feed her. And the many clinical specialists involved were deeply uncomfortable with that because they couldn't tell exactly to the like decimal point how many calories were in this meal, in each meal. And so there was constant conflict about this. And she felt like she was being questioned as a mother, as a person who wanted to care for her child. And so what ended up happening was an ethics consultation. Now, I will say there's a lot of ethicists in this room, so I'm curious. I'm curious if this aligns with your experience, but usually, I've never been in a clinical scenario that didn't keep me up at night, where we called ethics, you know, like no one calls ethics because stuff is going fantastic and we're really happy and all of that. You know, ethics gets called in these scenarios, and often I think ethics gets called when there's a conflict between what we think we're supposed to be doing and what we're actually doing in many of these cases. And so they get called, and the idea behind the consultation is help us figure out whether or not it's allowable for us to send her home. I'll point out that the other I put like right and left hand of difficult patient interactions is like ethics and legal. Legal had been called days before. And legal was like, you should keep her here and feed her and prove it, right? So here we are. Okay. So a pause. At this point, about 3 or 4 days into this, and hours, and I do mean hours of meetings. This was at the end of my intern year. For those of you who are familiar with clinical like medicine and residency training, intern year is like arguably the worst year. And by the end of intern year, if any shreds of your soul are still intact, there's like something really sparkling and wonderful about you. So it's May of my intern year, and I'm like, oh my gosh, I don't know if I can keep doing this. We have to figure out another plan. And I'm thoroughly and like floridly burnt out, right? And I think the other thing that I'm realizing is that I'm like, I'm not sure that structural competency is really helping me with this, right? If anything, the fact that I can see the stuff and don't have like some framework for what the right thing to do about it is even worse. I'd almost rather I couldn't see it. I'd almost rather I didn't feel like we were causing suffering to this family because there's a clash between the socio-political and cultural position of the care team and the patient. And knowing that, not doing a lot for me, right? And I was really, 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 really burnt out at this time. And especially about the fact that, again, like I'm at the node of trying to negotiate the complex interactions between this care team and this patient. And so I started looking for the resources to help me figure this out. And one of those resources might be the fourth year ethics class that I had to take as a medical student right before leaving to become a resident, which I think varies even more widely than like your cultural and structural competency education across medical schools. And in my case, was mostly about like sort of structured ethical conundrum cases that we would, like, is it okay to, prescribe medication to one patient who has health insurance so that they can give it to their family member who doesn't? Or how would you weigh these core principles in this particular scenario? But not necessarily like ethically muddy quotidian ethical decision making that actually characterized the kind of choices I was going to make. Which is just to say that I was pretty burnt out primarily because of that. And after a while, I started to experience a lot of moral injury. I started to have a really strong reaction to going to work. It's probably why I got the gray hair. And I really started to be like, I just am not sure. It was a sort of a moment that crystallized everything about being a doctor that was not in line with what I thought it was going to be, right? And feeling like I didn't have the autonomy to make the kinds of choices that I wanted to make. Interestingly enough, when I gave this talk to the rest of my residency program, there was a deep and profound sigh at this slide. And we spent a lot of time talking about all of the behaviors that had emerged in people's lives as ways of coping with these conundrums, right? All of the ways of shutting down or reacting or all of that. And I think a lot of those behaviors that like get read as callousness or get read as not caring or get read as being an unfeeling person, et cetera, that are really, I think, about for a lot of people overwhelm, and the overwhelm that I certainly felt. So thinking about moral injury and burnout, I'm really curious, since we have some ethicists here, if you had been called for this case, I'm curious about how you would rectify the differences between what the care team wants and what Rachel desires. And I'm really curious, one, too, if the answers are different than when I asked my peers, which I will tell you. Anyone have any thoughts? Yeah.
Well, you said with regard to that first question, you said that knowing without being able to do anything about it, like having no framework to use that knowledge to actually improve the situation.
Yeah.
Like that.
Yeah. Totally, absolutely. Yeah, being able to watch, because of course you're watching the interactions too, so you can see it unfolding. And I think, there's a lot of bystander training that says like you should name it, but I think it's actually kind of a hard thing to name. Like people don't generally like being told to their faces that they are committing acts of racial bias, for example. It doesn't often go that well in practice, even if we train people, in fact, to do that. Yeah.
Oh my God. Actually, the question, I was curious how you gleaned the insights that you did about mother in this case. And whether you shared those insights with other people or there was an opportunity for the ethics community to develop that kind of insight.
Yeah, that's a good question. I gleaned the insights by talking to her, by asking her. And that took several days because when I first met her, she was like, I would describe her as, it's worth saying, I didn't not experience her similarly to the way that I think our nursing staff was. And part of that is not because that's necessarily my own personal background. Like, I don't share a background with the nurses on our floor, but I think it's because I'm so used to a kind of like Northeast communication style that it is different when I experience it differently. But after a couple of days, after a very honestly, like really terrible situation in which there was a threat to call security and remove her forcibly from the hospital, we ended up having a really long conversation. And she told me like a lot of things about her past and how many family members that she lost, including one family member that she lost to gun violence, like while they were in the hospital. But I think, to be honest, it's worth saying I was the only person on the care team who heard that information from her directly, which I then usually communicated in these meetings. We were having meetings about her, like, say every day for several hours with lots of people involved. But I think the therapeutic alliance had been so broken between her and many of the other members of the team that I don't know that a lot of people knew her particularly well.
Just curious if the care team saw you as a credible representative of that information.
What an interesting question. Yeah, so yes and no. I mean, I think part of the reason, because I think like the elephant in the room obviously is, of course, I'm also a Black woman, right? So part of the reason I think that Rachel and I were able to have some alliance with one another is because I'd already spent a year in this children's hospital, and I like know how people speak to and interpret the speech of Black women in the hospital. And so I think that she believed me when I said that I didn't think that she was aggressive, right? Did I think that she was upset? Could I feel that affect wafting off of her when she was interacting with me? 100%. Did I feel that she was attempting to like attack me? No. And I think the fact that I didn't react that way was part of it. But when I communicated that I thought that perhaps some aspect of this had to do with the fact that that particular floor was probably like the worst in terms of racial, class, gender homogeneity in the entire hospital, that wasn't received well at all, even a little bit. And I mean, I think with each passing day, I became increasingly more outspoken and probably was read very similarly when I would be on rounds. And I would say, I think we should send this child home. And I think it's immoral that we're not. And that obviously also didn't go that well either. So that is an astute question. Yeah.
I keep wondering whether another elephant in the room has anything to do with death.
Mm-hmm.
And we know that clinicians are trained to avoid it at all costs. That may or may not be the case for all cultures. And sort of, was there any discussion about the likelihood that this child would die, might die, and the mother's desire to have her die on her own terms, as against the clinician's desire to like force feed her no matter what?
Yes. That came up all the time, and that was the real conundrum, right? Because I think, so as somebody who works in both adult and pediatric medicine, I would say, like, I mean, adult doctors obviously also don't want their patients to die, but their patients die a lot, right? And it's like, and I think there's a lot of, at least in my experience, a lot of the qualms we have around death often tend to be around like our evaluations of what constitutes a good or a bad death, right? And again, we want to avoid death, but I think when I'm working on an adult medicine team, the idea that some of our patients might not survive the conditions is something that we come to accept. And I would be surprised if I had a single colleague who made it through their first year without a single patient dying. In pediatrics, honestly, kids don't die that much, right? And I think the idea that the child would die is really hard for people to accept. And my Rachel's understanding was, of course she could die, but they've been telling me she could die any minute for 3 years. And I've come to accept that. And I've come to accept those risks. and I'm comfortable with it. And I'm also comfortable with the idea that maybe she's showing us that now is about her time, which is even more the reason I don't want to be here. As opposed to, I think, the pediatrician impulse, which is very few of my patients die, like even on, as a case in point, when I was on the oncology service, I had a patient who, at the pediatric oncology service, had a patient who was almost certainly going to die. And I asked my attending, who was not going to be there overnight, you know, what they wanted me to do in the event of that. And they were like, oh, I mean, I very rarely do any of the death paperwork. Like, do you know how to do death paperwork? And I was like, I do it all the time. And they had not ever done it. Right. And so like, that is how much of a rare event it is, even in the place where you would imagine children die all the time. So when she would say, I'm comfortable with that, everyone would be like, well, if we didn't try to avoid her death and we didn't prove to ourselves that we could avoid her death and we sent her home and she dies, like, what does that mean about us? Right. Like, and I think the fact that it was actually unknowable whether her death was avoidable in this particular instance was very, very hard for people to cope with. Yeah. Go ahead.
So just to answer your question, last question, which is something I've been thinking the whole time. I'm not a clinician, so if I were given this case as you presented it, I would fully defer to her. Because for exactly the reasons that you said, which is it seems like the doctors are only pretending to know what the right course of action is. Because there is no evidence, this is a very rare disease. The child has outlived the expectation, and Rachel has been the one responsible for that. So she seems to know what to do better than any clinician does. And so, you know, it seems like she gave that reason as well, and it seems like the right one, which is she's been doing it. This child's lived for 3 years. You don't really know what you're doing. And that's the thing.
You know, she actually may have said that exact sentence.
And it was so like, I don't know what further reason the clinician could give.
Yeah.
Was there any reluctance on the side of the care team to disclose that unknown?
So it's interesting. Because I think that varied a lot. We, of course, this stretched over the course of 2.5 weeks. So in that time, there were 3 different attendings with very, very different styles and comfort. One attending, I think, telegraphed and communicated a tremendous amount of uncertainty, so much uncertainty. Softly irritating amount of uncertainty. And, but the uncertainty made her say, we can't make a choice. Or rather, she doesn't want to make a choice that's a deviation from what we're already doing, right? So the patient's already in the hospital. To discharge them would be to make a choice. I made the observation that continuing hospitalization is also a choice. But that, for her, taking on the responsibility of having, because she wasn't the first attending to decide that we were waiting for growth, right, was too much for her to do. Others, I think, were comfortable with the uncertainty, but felt that in the absence of certainty, we should collect more data. More data means more hospital. And that we should capture data that was perceived to be more objective. And what I mean by that is we should convince Rachel to give the child standard formula with standard calories and see what her weight response is to that. And then finally, the last attending, who, spoiler alert, did what I wanted her to do, was like, since we don't know, she should go home. But that took a while to get to, and took some ethics consultation, kind of, about it as well. Yes.
So like when this is a very familiar kind of case. And your first question about burnout is bi-directional and moral injury, because clinicians are trying to uphold their values and their identity as good doctors, good nurses. And the mother is too. She is trying to be faithful to her image of being a good parent. And so you can imagine when you put those two together, the dissonance and the conflict really starts to have some pretty profound impact, both on the relationship and on the people. When you think about clinicians, what part of our identity is fixing problems, right? And this is a problem we couldn't fix. So we feel ineffective, we feel powerless, the things we're using aren't working with interacting with the mom and also in our treatment. So it's got all the ingredients of a really intense kind of space where everybody shows up. And I wonder about, in circumstances like this, what you did in terms of bringing the voice of Rachel in a different way into the conversation could be an opportunity to have the team reflect on whether or not what they're proposing, in that realm of certainty and uncertainty, where it fits. And what degree of latitude do we then give to parents when we are uncertain? Because a lot of times this unfolds with allegations that this parent is not acting in the best interest of their child. We should call Child Protective Services. And it goes down that whole line. And so, I think it's just an interesting, a way to engage in why might we be treating this case differently than others? What would be those factors that might fit into the structure on the cultural realm?
Yeah, I totally agree with you. And I think it's funny because when I think about the cases that have kept me up at night, there's the ones where the family is given no latitude, like this one. And then there's ones where the family's given latitude in ways that feel off. An example is that one example, for example, is I've had several patients who had poor prognosis malignancies in adolescence, right? So imagine you're 14, 15, 16 years old. You know what it is to die. I mean, you don't know how it feels to die, but you know about death. And we've had cases where families said, you can't tell them the results of the scans. You can't tell them that they're passing away. You can't tell them that the treatment's not working. And we might switch their chemotherapy over and over and over again and not disclose to them the reason for that. And for me, I'm I'm a pretty smart kid. I think they could probably figure out why we're switching, and in my own value framework, I'm it is a missed opportunity to support them through the experience of having something happen to them that's not going well, and a missed opportunity to shepherd them to end of life in a certain way, and signals that we value their parents' feelings over theirs when they're old enough to be able to tell that, right? But in those cases, I would say universally, we have capitulated to the parental desire to not disclose, at least in my institution, in ways that even our psychologists are I think that's probably harmful to kids, in a way that there's more certainty about than this situation, right? So I think that is really an interesting question too, that I think most of the time, I feel we allow parents to guide the way unless we think it's harmful. And what we consider to be harm feels to be unevenly applied, like so many other things are. Yeah.
So kind of along those lines, I was wondering if there's any discussion about, bringing Rachel in as part of the multidisciplinary care team and as primary caregiver. I know I have an infectious disease physician, so I know rounding with a family member present sounds very different than rounding when family is not present. But just was, in terms of your last question, curious if that was ever part of the discussion or if it was felt that the care team's interpretation of Rachel's behaviors were too discriminatory, that to be constructive.
Yeah, that's a great question. I think so. In our PEDS institution, I think of pediatrics in general, there's this concept of family-centered rounds, right? Where you do all of your rounds in front of the family, always. And that is true, we do that. But it is interesting, among the many other things that are interesting, which families we stop family-centered rounding and maybe one or two people from the care team circle back to speak with the family after the sort of standard structured rounds. And I will say that over time with Rachel, that is sort of how things ended up going, because we would be on rounds with the whole big team, the way we normally do rounds, the whole big team. And then there would be often open conflict between whichever primary nurse was caring for Lily that day and Rachel, to the point where then the rounds would expand to fill the time they were given. And there's of course this other looming problem with rounds, which is that they're supposed to be done by a certain time so that we can do things right. So that there's that aspect. And then there's the other thing, which is what would often happen, which would be that we would have these afternoon multidisciplinary care team meetings where we would decide as a group what we wanted to communicate with Rachel, and then have the second subsequent meeting where she would come at the back end to have a negotiation with us. And part of that was because we were suppressing, this is an interpretation, I am interpreting that we were suppressing the fact that she could probably perceive that there was internal discord about what we should do. That the nutritionist and the GI doc and the primary team and the palliative care team, who was involved always the whole time, all had different thoughts about this. But because we were attempting to say, it is definitely the right thing to keep her in the hospital, we were having these meetings where we were like, all right, which one of us is going to say it is 100% the right thing to keep her in the hospital? And then that person, the person who it was perceived she trusted the most, which was interestingly not me, was the one to communicate that information with her. And yeah, I mean, I think those things were not, but those things were importantly not conversations. They were like negotiations, which is a different kind of clinical encounter. Other thoughts? Yeah.
So how did the ethics committee become familiar with her situation, and what kind of resolution did they come towards?
Right. An excellent question. So the very, very uncertain attending is the one who eventually involved ethics. And at least our ethicists, I would say, one, did not necessarily comment on the nature of the communication and those aspects of what was going on the floor. And we're mostly concerned with the question of the feeding and the growing and the discharge. So like, I would say a relatively narrowly scoped set of questions about what we should do next, because that was the site of uncertainty. And their thoughts were essentially that, one, they were like, oh, this is a hard question. One. And two, they basically said that it would be reasonable to do either. And that I don't make the rules, I just work there, you know? And it would reasonable to do either, that they would advocate that they felt strongly that it made sense why Rachel wanted to leave, and that we needed to, at the very least, like focus on repairing our relationship with her, and offered some suggestions about that and facilitation around that, but didn't say the thing that I sort of wanted them to say, which is that in the absence of knowing, we should probably lean towards allowing her to go home. The actual ultimate outcome is that the last attending to work with her, who is relatively high up and a very experienced clinician, got the case. And on the first day we were on rounds, and I said, I'm going to say what I said the last 17 days, that we should send her home. And she said, sure. And that's what we did. Which makes, I have so many thoughts about that. But anyway, and the end outcome is that in the end, about a week after she left the hospital, Lily did pass away at home, where her mom wanted her to. And which I think was what everybody knew would happen if she left. And she called, I am close with the palliative care doctor who worked with them. And so the reason I know that is because the palliative care doctor called me to tell me that that had transpired, and that she was happy that that's the way it went. And that's what she had wanted the whole time, because I think she knew that she was going to pass and didn't want her to spend the last few days of her life in the hospital getting mysterious tube feeds. I think that there are a lot of other things that transpired, which is that we have a sort of reporting tool for challenging interactions, as we call it, where we can like name things that are not going well, that I wrote a borderline essay in about this entire situation, which resulted in implicit bias training for the nurses on the floor. So you can make of that what you will. But I think one of the things that, and I'm happy to talk more at length about this. One of the things that I think it made me think about was that I feel pretty strongly that I think having a better framework for that interplay between the sort of structural and intimate, and being able to point that out in ways that are helpful from an external observer in teams is something that I have often wished was a part of the ethics consultation, because most of the time that I've experienced ethics consultations, they've been in scenarios where that was one of the many elephants in the room, in addition to the things that we're accustomed to having ethical conundrums about, like, you know, what's a good life and death, and when we should treat and when we should not treat, and how we should, all of that other stuff. And then there's also just these other things that are like, there are lots of different kinds of people in the world, and often they have to make decisions together in ways where that is a primary conflict that often doesn't get named. And there's no other entity technically who we ask in the same ways to resolve those for us. I mean, we ask social work in a certain way to resolve those for us, but kind of differently, more in a directive way. And then the attendings ask legal to resolve that for us in other ways. But I think of it as a potential role for the transformation of ethics practice to be part of thinking about structural racism and gender inequality, et cetera. I have more thoughts, but I'll pause there because I think it's time for Q&A. Yes,
Is this your last?
it's not, but it will be now. Yes.
Do we have 8 minutes left? We've had a fair amount of discussion, so if you want to finish your slides, you should feel free to do so. But we can also stop and.
Pause. We can pause for a second. Yeah, we can stop and have conversation.
Thank you. All right, so we have had some conversation about the case in particular. Does anyone have any questions or conversation they want to have about perhaps the broader point or anything else from?
Thank you so much. It's a great talk. I actually sit on the structural competency working group in the School of Medicine here. Work closely with Carolyn Suffren, who's one of the people who said, "Oh, she's so great." Anyway, can you say, medical education was in your title.
Yes.
Can you say a little bit more about how you weave all of this into medical education?
Yes, I'm so glad you asked, because now I can show you the slide I say. I knew someone would ask. Okay. All right. So, you know, I'm still thinking about this, but personally, when I was talking with my peers about this case and their conundrum cases that they were thinking about, and I asked them, basically universally, we all went to different medical schools. Universally, everyone was like, okay, I did learn these ethics. These were my ethics. And I was like, amazing. Do you think that trying to focus on non-maleficence is going to help you figure out what to do for Lily's case? I was like, well, no. I mean, yes, it helps you decide what you want. But like, I think every doctor in the case was like, I don't want to hurt anyone, right? You know, like I want to do good things for people. And so, you know, we were talking a lot about this. And I think obviously there's nothing wrong with, that's not true. There are complicated critiques that could be made of these 4 principles in terms of their applicability across cultures and the relative weighting of each, and whether or not like autonomy matters as much to everybody as like it might to certain people from particular backgrounds. And so while I was like, you know, reading about this and trying to figure it out, I mean, I think that the challenge in medical education, right, is you can't, somebody who's taught a lot of medical students, you can't just like say some ideas. There has to be like a framework, right? And it has to be pretty concrete. And so one of the things that I have seen circulating that I think it was just presented a few weeks ago is a modification to the 4 box method. Right. And so the interesting thing is that I was curious about how my peers would respond to one, having these things that they're thinking about concretely, and then two, to trying to transform the questions in the way that let's see, that Campilia, James, Olszewski, and Vo did. And they responded very well to that, to this idea that like, if there's a concrete set of things that you're thinking about and questions that you're able to answer, that you could change, for example, your questions about medical indications to think about like how we might approach diagnosis and treatment across different contexts for this patient, or who has gotten to participate in defining the goals for medical treatment, or thinking about structural vulnerabilities and what that means for the aspects of treatment that make sense. So I think about this a lot in terms of like the NICU and resuscitation, right? That like the structural vulnerabilities might make a significant difference in like what it means to offer resuscitation to infants at increasingly lower weeks of life. And that actually seemed to work really well. And people felt very strongly that they could apply those frameworks. And it didn't necessarily mean that there was more clarity, but I think it was less amorphous for them than the experience of being like, I'm not sure how to interpret what justice looks like in this context. And I sleep 4 hours a night, so I need to be guided to some conclusions, at the very least, about what feels uncomfortable and fraught about this, that help me think, how can I bring, what kinds of specific questions could I be asking of how we're doing this as a team, or doing this with Rachel or any other family member to elicit more participation in this context. So I think this is a paper that's about to come out. I'm very excited about it. So anyway.
Anyone else? It's on.
I'm gonna say mine for dinner because I don't know how you can do it in 4 minutes. How do you think about the implications for other patients on the care team? I mean, other patients on the floor when they're spending hours in team meetings because of this challenging interaction?
Yeah.
As you said, you just don't sleep, and that's part of the solution, but something else has to.
Yeah, I completely agree with that. That actually is something that causes me a lot of distress, is because I actually just had this experience 2 weeks ago that I'm happy to talk about at dinner, where I felt very strongly that the challenging interaction actually like did actively negatively impact other patients on the floor in a lot of different ways. And then I think that has to be part of it too. But I think we often don't at least verbalize that like time is finite and a clinician attention is finite. And the other thing being that like, if you are morally distressed and like emotionally activated, it's kind of hard to think clinically in the same ways that you do when you're feeling like there's an alignment between your values and your job. And I think that has to be a chunk of it as well, right? It's like, at that time on that floor, there was this patient, and then there was another patient who had been in the hospital for like 300 something days and was like a very well-known patient to like every single pediatric resident, because interactions with this family are like formative in like a hazing way, not in a transformative way. And I think that matters because it changes people's experiences. And also, interestingly, I had an experience where one family wanted to leave the hospital because they were in a shared room with a very difficult patient situation where the family member was like escalated and screaming for days. And, so there's that also, just like concrete impact on other patients too. Yeah.
You have time? Sorry. Thanks. Yeah, thanks very much. I was just thinking of Cinda's comment about the bi-directionality of vision and tying this in here. I think I was wondering about, well, the simple question is, did the ethics committee talk to Rachel directly?
Yes.
And how did that go? But it feels to me like there's some capacity for clinicians to just offload the moral distress to the next clinician and then go on to another distressing thing, right? So there's this kind of shared distress. Whereas for a mother who's trying to advocate for their child, it's all on her. And so what offloads do you see as being more effective or less in the context on the patient side of things?
Yeah. I think about that a lot because I think, well, I mean, I think the ethics committee did speak to her. She was not particularly trusting of them. So I don't know that they directly elicited some of the things that I knew about her, right? And I think she had a lot of trauma, and I think this experience itself was very traumatizing for her. And I think one of the things that I perceive is that there isn't enough support. I mean, there's palliative care, which is like one way of offloading the trouble of like caregiving, but a limited one, right? And I think, you know, palliative care in its best form can be a form of like shadow advocacy for families and really participate in that. And I think they tried to do that for her, but you know, they're still not there at the bedside, like every minute of every day, having those like battles. And I think I often wished for Rachel that there was something that we had where there would be some other person who's there at the bedside every day to help. And, you know, in truth, it's often said that nursing is supposed to be that, right? That like nursing is they're also at the bedside and supposed to be advocating for patients. But I think if the conflict is with the other bedside caregiver, I don't think that, like, I think the very worst cases are ones where the actual conflict is between the bedside nurses and the patient, because there's often no real pop-off valve for that. And as much as I can try to structure some interactions, like the 1,000 different interactions every day around vitals and medications and feeds and et cetera, like, and are impossible to control. So yeah, I think I'm like much more concerned with how hard we made the last month of her daughter's life than I am about how hard it was for me. But I think the reason why I think about the burnout and moral distress is because I have to imagine that not having the skills to cope with what was very apparently a dying child is probably part of the distress that caused the challenging nursing interactions. So it matters in some meaningful sense to how Rachel experienced it.
Thank you so very much. It was